Hi, guys.
Good evening, everyone. We are going to let all the attendees in here and we will get started in just a moment. All right. Hello, everyone. Welcome to today's webinar on functional GI trends, including a 2021 year in review and 2022 outlook. On behalf of Commonwealth Diagnostics International and My GI Health, we are excited to host today's discussion and Q&A on timely themes and new research impacting the GI community. CDI's mission is to help providers better identify and diagnose common sources of digestive distress and functional GI ailments, with a focus on developing a portfolio of non-invasive and cost-effective diagnostic solutions that result in expedited treatment, better patient outcomes, and robust cost savings for the entire healthcare delivery system. Our expansive portfolio includes non-invasive at-home breath testing for SIBO, IMO, and carbohydrate malabsorption disorders, as well as IBS Check, a proprietary capillary collection test for irritable bowel syndrome, and My GI Health, a cloud-based healthcare platform that enables patients to manage and understand their symptoms while enhancing the patient-provider relationship. CDI is also at the forefront of GI research, working directly with sponsors, CROs, and principal investigators of clinical trials worldwide. You can learn more about CDI's diagnostic products and solutions at comdx.com. Just a little housekeeping before we get started today. Today's panel discussion is being recorded and will be available to the GI community following the event. If you have any questions during the panel, please type them into the chat box in your Zoom control panel. We will try to cover as many questions as possible during the discussion and the Q&A at the end. Now, without further ado, I'd like to introduce our industry moderators for today's panel. Cecile Rooker is president of the International Foundation for Gastrointestinal Disorders, or IFFGD, a nonprofit patient education and research organization. She has extensive background with over a decade of experience in the field of functional GI and motility disorders. She is an IBS patient herself since childhood and has spent the majority of her career working with patients as well as health professionals and educators to improve FGIMD education and patient care. Prior to joining IFFGD, she served as executive director of the Rome Foundation in the GI industry as well. And Craig Strasnick is a seasoned executive, experienced entrepreneur, and dynamic commercial leader. In his current role as president and CEO of CDI, he partners with respected academics and industry leaders across the world to improve current GI practices. He drives the company's mission by developing and introducing new patient-friendly preventative health and monitoring technologies, as well as ensuring their clinical and commercial execution. He's also currently a board member for Functional Gut Diagnostics, a CDI joint venture in the UK, My Total Health, developer of the My GI Health platform, and GI Logic Inc., creator of AbStats, a non-invasive GI biosensor device. Cecile, Craig, great to have you here today, and I will turn it over to you.
Well, it's a pleasure to be a part of this, Jason. A big thank you to you, your entire team, for all the hard work that you guys have put into coordinating this event and putting it all together. We have really an all-star group of clinician leaders from all over the country joining us as panelists tonight, and we couldn't be more grateful for all of their participation. And finally, to everyone who has registered and is joining us in the audience tonight, we thank you for being here. We're excited to dive in, and we'll do that beginning with the introduction of our panelists. I have the honor of introducing our first, which is Dr. Brennan Spiegel. Dr. Spiegel is the Director of Health Services Research for Cedars-Sinai Health System and the founding director of the Cedars-Sinai Master's Degree Program in Health Delivery Science. He also serves as Cedars-Sinai Site Director for the Clinical and Translational Science Institute and is Assistant Dean for the David Geffen School of Medicine at UCLA. Dr. Spiegel directs a multidisciplinary team that investigates how digital health technologies can improve people's lives. His VR research won the 2017 Webby Award for Best Technology on the Internet. And in 2020, he published the book VRX, How Immersive Therapeutics Will Transform Medicine. Dr. Spiegel just recently passed the baton as the editor-in-chief of the American Journal of Gastroenterology and was among the first group of clinician researchers to examine the gastrointestinal manifestations of COVID-19. Next, we have Dr. Kavita Kongara. Dr. Kongara is a board-certified gastroenterologist currently treating patients in the metro Atlanta area for Atlanta Gastroenterology Associates. In addition to her special interest in overall digestive health and colon cancer screening, Dr. Kongara treats patients for a wide variety of esophageal and colonic disorders, such as GERD and IBS. Prior to joining Atlanta Gastro in 2010, she spent nearly a decade in academia and practicing medicine for institutions, including the Cleveland Clinic, the State University of New York at Stony Brook, Winthrop University Hospital in New York. She also currently serves as medical director of the motility at Northside Hospital in Atlanta. With that, I'll turn it over to Cecile to introduce our next two panelists.
Thanks, Greg. I have the great honor of introducing two great friends to patients with gastrointestinal illness. The first is Dr. William Chey. Dr. Bill Chey is a gastroenterologist and Nostrum Professor of Gastroenterology and Nutrition Sciences, the Director of the GI Physiology Laboratory, Director of the Digestive Disease Nutrition and Lifestyle Program, and co-director of the Michigan Bowel Control Program. His research interests focus on the diagnosis and treatment of disorders of brain-gut interaction and H. pylori infection. He is a medical innovator and holds 4 patents. Dr. Chey has authored more than 350 manuscripts, reviews, chapters, and books, and is the former co-editor of the American Journal of Gastroenterology. He currently also serves as the board member of the Trustees and Practice Parameters Committee of the ACG, is a member of the board of directors of the Rome Foundation and the board of directors of the International Foundation of Gastrointestinal Disorders, or IFFGD. Last year, he was awarded the prestigious Burke Weiss Award from the ACG. Also with us today, last but definitely not least, is Dr. Darren Brenner. Dr. Brenner is an associate professor of medicine and surgery in the Division of Gastroenterology at Northwestern University and serves as the director of the Neurogastromotility and Functional Bowel Programs, co-director of the Integrated Bowel Dysfunction Program, and director of the Mott's-Tonelli GI Physiology Laboratory. He is also an active Irene Fitzer Research Foundation scholar. Dr. Brenner focuses his clinical research pursuits on a wide range of motility topics, including IBS, constipation, opioid-related constipation, fecal incontinence, gastroparesis, and scleroderma. He has published more than 150 articles, abstracts, and online materials on these subjects and has lectured both nationally and internationally in all of these areas. He is a prior associate editor of the American Journal of Gastroenterology and a fellow of the ACG, AGA, and the Rome Foundation. So to start us off, Dr. Chey, you recently gave a lecture at the American College of Gastroenterology meeting in Vegas, and it was on the current megatrends in GI. Can you talk about the 3 biggest trends that you discussed during that meeting?
Sure, Cecile, and thanks so much to Craig and everybody else at CDI for the invitation to be part of this panel. During the Burke lecture at the American College meeting, I talked about 3 big spaces, and one of them Brennan could probably embellish on as well, since he's really an international expert in this area. The first is nutrition. I think that in the past 10 to 12 years, nutrition has really gone from more of a fringe interest in GI to really a foundational part of treating virtually every major type of GI or digestive disorder. Think about it. Diet really is foundational in inflammatory bowel disease, functional GI disorders like IBS or dyspepsia, constipation, diarrhea, eosinophilic esophagitis, and many other diseases. The other big trend that's occurring before our eyes has to do with behavioral health. I think now it's fair to say that diet is an evidence-based form of treating patients with digestive disorders, and behavioral health is also an evidence-based means by which to address patients' GI symptoms. You know, the latest network meta-analysis that was published on behavioral therapies for IBS included data from 41 studies, 41 randomized controlled trials. That's actually as many or more than most medical therapies, actually a lot more than most medical therapies. So things like cognitive behavioral therapy, gut-directed hypnosis can now be considered equal partners to treating patients with conditions like IBS, but really far beyond IBS. And then the last thing brings all these things together. If you think about medications, which still play a really important role, medications, diet, and behavior as equal partners and not independent variables, but codependent variables that can be utilized to varying degrees in the patient in front of you. The real question is, how do we bring this all together, and how do we make decisions about what's best for each individual patient? And that's where this discussion of the third big thing, integrated care, really comes in. So this concept that these different types of healthcare providers, physicians, dietitians, behavioral psychologists, maybe even psychiatrists, need to work together to develop a collaborative integrated care plan for each individual patient. And we're far from that at the current time, but you know, at places like UCLA, Northwestern, University of Michigan, and I think Atlanta Gastro has very much jumped on board with this as well. So large practices now, this is really becoming much more the norm than the exception. And that's really, really exciting. I think the thing that I'm most excited about is the ability to scale integrated care services through technology, you know, through the use of mobile applications, virtual reality, which is something that Brennan is probably the biggest expert in the United States on. And virtual care platforms. We are literally going to be able to provide full stack integrated services virtually anywhere in the United States. So we are witnessing a sea change in gastroenterology right now, both in terms of care and also in terms of the money that's going into developing these virtual platforms. You know, it's been estimated that anywhere between 500 million and $1 billion per month is going into the digital health space. So obviously, people in Silicon Valley, people in the equity markets are willing to place pretty big bets on this space because they think it's the next big thing. And I have to say, I agree with them.
Thank you. Thank you, Bill. That is fantastic. And I think we can all agree that these are definitely, you know, three trends that we've been seeing and we're seeing more of. Dr. Kongara, I just have a question. Bill had alluded to the fact that maybe Atlanta Gastroenterology has included sort of this integrative care with the dietitians and the behavioral specialists. Is that true?
Yes, that's true. And we are now United Digestive, not to lead to any confusion, but
Okay.
we are growing as we speak. So yeah, you know, I think the strength is in our numbers. And so we were able to work with sort of, you know, separate dietitians in the community and pelvic floor therapists. We still have a little bit of a ways to go to find cognitive behavioral therapists. That's very tough, but we found psychologists. So kind of brought them in. And when I came in 11 years ago from an academic center, in addition to building the motility lab and providing the motility studies, this was key as well in terms of really practical care, day-to-day care. I mean, we all, you know, do endoscopies, colonoscopies, but really when those are done, hopefully the majority of those are fairly, you know, unrevealing and show normal mucosa, but the patient's still suffering and the patient has symptoms. And so luminal disease, which leads to, you know, a lot of these functional disorders and what we do, I just think there was a big gap in the, you know, the first 10 years of my career. So Atlanta Gastro, because of the size of the city and the growth that Atlanta's had, we sort of started by having a circle of referral base. So, practitioners that trained at Emory, which is our big teaching hospital here, may have come into the community. We found colorectal surgeons that might have used pelvic floor therapists if we didn't have our own. There was a wonderful company that came together outside of our group called Modify Health that sort of works with patients so they're not on their own doing FODMAP diets and what have you. So brought all these pieces together to our group so that now when patients are seen, we have an easy referral network that are actually accessible. And many of these providers take insurance, which in the real world is a big deal to a lot of patients.
Absolutely. So, so thank you so much. That was actually my next question is what sort of advice would you give to other GI practices out there? So thank you for reading my mind and answering that ahead of time. And what you were just saying is some of your nutritionalists and therapists are actually covered by insurance. We actually do have someone in the chat had mentioned that that is an issue for some patients, and I know that it is. Is that something that you've been able to?
Well, I'm going to clarify. So some of these, like therapy, is covered, like pelvic floor therapy can be covered. I mean, it depends on the patient's insurance. Dietitians, nutritionists, if you have certain medical conditions, which a lot of our functional patients may not have, may not be fully covered, but in bringing a patient to a program that has a dietitian, and this particular one makes meals that for the patient that they can purchase. So it's sort of a full service circular care. And so they may or may not be covered by insurance, but the patients are finding it very affordable from point A to point C. Everything's up front. So there are no hidden costs. They know what they may have to pay. They know what they're responsible for. And the feedback I've heard from a lot of patients is that it was worth the investment that they made in terms of follow through, because a lot of these things on their own, it's like exercise, getting a personal trainer or doing it on your own. This is their personal trainer when it comes to dietary therapy. So yeah, that we still have to work on. In terms of psychotherapy, my colleagues can chime in, but I think that's insurance dependent in terms of psychiatrists, psychologists. So again, we try to find providers that are accustomed to working with our patients so that it's very clear in terms of how many visits and what they've done and how they've helped. And again, it may not be accessible and covered fully, but patients are finding it reasonable and worthwhile for their overall health.
Great. Thank you so much for those insights.
Yeah, those are really fantastic piece of information. I think I'd like to pivot a little bit too, and I think this is a good segue into just the post-COVID environment at large and some of the macro trends there we're seeing on the research side of things, but also some of the practical implications that we're seeing in clinic. Before I do so, I see that there is our first question of the evening from the audience, and while I think I know the answer, I certainly don't want to be presumptuous. So I think I'll open this up to our panelists. Maybe Bill, I'll circle this one back to you, and we'll try to, depending on how many of these are coming in throughout, we'll try to answer these in real time if we can, but if not, we'll certainly make sure we follow up and get answers to any questions that the audience has. But this one here is, hi, are all of these panelists integrative GI? Bill, I would maybe go back to you. I'm not sure categorically if that is how you would consider yourself in practice. The way I would kind of think about it is that you integrate a lot of ancillary services into your core practice.
Yeah, a lot of this really is semantics. So when I think about integrated care, I think about the incorporation of behavioral and nutrition services along with traditional medical care by a Western physician. When I think about integrative care, I think about a complementary alternative medicine provider in addition to those other assets. So, and this is different people sort of use this terminology differently, but I would not consider myself to be a naturopath or an integrative care provider, i.e. a CAM provider. I don't have formal training in that regard. But I don't discount those providers at all. Like if somebody's already seeing one of those providers, I'll definitely try to work along with them as best that I can, recognizing that oftentimes the naturopaths have a very different way of viewing and approaching problems like IBS than a traditional Western physician would. So taking all those things into consideration, definitely try to work with those alternative providers as best that I can, but we sometimes come at it from quite different angles.
I think a lot of the times too, at least what we've seen in our experiences is that the patient mandates a lot of that cross interaction between the allopathic provider and their naturopathic or integrative provider. A lot of times they're bringing a lot of the data that they've gotten from one provider to the other, and that may be helpful in, an ongoing continuum of care, especially in, chronic care management of a disease like IBS or others. So yeah, I think it's certainly helpful, and thank you for those insights. So I'd like to pivot back again to just kind of where we are now post COVID. The world has certainly changed and has kind of spun its axis, and the field that we all operate in is certainly not privy to being expelled from that. So I'm wondering, Brennan, I know in our mid-year trends webinar, you had discussed the COVID-19 impact on GI patients, and your team recently published some new data on the prevalence of functional GI disorders throughout the pandemic. I think generally, I'd like to just ask kind of what did you find and what is most interesting to you there?
Yeah, thanks, Craig. And thanks again for inviting me to participate. It's a great group here. So, it's been amazing. I'm on service right now. I just did a procedure in full PAPR. I had a patient with active COVID just came across the street. And it's just a reminder that this isn't over. We're still seeing COVID right now. I'm sure where all of my colleagues are as well, maybe less so than we were a year ago, but it's happening. But it's really amazing to think back a year and a half and how much we've learned during that time about this disease and about its impact on the GI tract. And in the past, I've in this forum talked a little bit about what we know about COVID and its impact on the GI tract. What you're referring to is we published an abstract at ACG just a couple of weeks ago. Bill's a part of this study as well, where we've been monitoring the population prevalence of various functional GI disorders, including IBS and functional dyspepsia and a few others, and comparing the prevalence from before the pandemic to just when the pandemic was starting. And now we've been measuring every month for approaching a year now. And so the upshot is we have definitely seen an increase in the prevalence of irritable bowel syndrome throughout the United States compared to baseline. Using Rome 4 criteria, we're seeing roughly 10% in our most recent surveys, compared to sort of a baseline closer to 5% or so, 5-6% using those criteria. Now, that doesn't necessarily mean COVID is the cause of all of this. I mean, a study like that poses more questions than it answers, but it makes you wonder, is this because of stress and anxiety that is occurring? This is sort of the pandemic from the pandemic, of the mental health pandemic. Is this COVID itself? Has there been a change in how people are eating? Tying in Bill's earlier, who knows? But we definitely are seeing an increase in both functional dyspepsia and IBS, although we're not seeing it across all functional GI disorders. For example, we did not see a change in chronic idiopathic constipation or opioid-induced constipation. We might have expected that with the opioid epidemic, but we haven't. And other forms of functional GI disorders, but dyspepsia and IBS, we have seen it rising. So that's some new information, and we'll be writing that up and submitting it for publication soon.
No, it's interesting, and this idea of just at large of disorders of the gut-brain interaction, and which one is causing the other, and in a post-COVID environment where stress and anxiety is peaked more so than in any time recently that I can recall, just at a society level, to see an increased prevalence in IBS and some of these other functional GI categories go along with that. It certainly begs the question of kind of causative action. So I appreciate those insights. And I think would transition Dr. Kongara to just some of the practical implications you're seeing in clinic, the effect that some of this is having real time day to day. I know in some of our calls, just in preparation for this event, you were saying that you're inundated with appointments from reschedules from during COVID or just patients that you had seen prior to COVID who are rushing to get back in because symptoms have come back more viciously than they were prior to. So I'm just wondering, the impact generally speaking, but, if you've made any changes in your practice to how you're diagnosing and treating patients with some of these functional GI disorders, if the symptoms are the same, if they're presenting differently, just anything characteristically that you're seeing that might be of interest.
Yeah, sure. I think I can definitely say this brain gut thing we're talking about is it the chicken and the egg. We know that patients with anxiety and depression often do have functional GI disorders and vice versa. You would assume if it's not directly COVID related, which I suspect it's not, I think it is the increased stress, kind of whether it's loss of job or just feeling more anxious. I mean, I'm seeing more patients there. I'm not surprised at all by Brennan's stats. I feel like half of my clinic might have been seeing IBS patients. Now it's 80%. I am seeing we're backlogged for follow-up patients, whereas in the past we'd see a patient, initiate some form of dietary therapy or medication therapy, all of these things together. And in all honesty, we were a bit slower in scheduling that follow-up, give the patient time to work on lifestyle, meds, these things. I feel an escalation. So an escalation in severity of their symptoms, the urgency to seek care. I'm using more, at-home tests, referring, escalating sort of just top therapies very quickly.
I think we lost.
Yeah. May have had a connection issue.
Patients can you hear me?
Oh, we can
Yeah.
now. I think we
Okay.
lost it for about 10 or 15 seconds.
All right, thank you. So I think because a lot of people are working from home, they are escalation in symptoms, they're seeking care, and we are using telehealth more. And so all of this has led to an increase in demand, but yet still, even with telehealth, an increase in demand such that we cannot, as big a group as we are, we're having trouble getting all of our follow-up patients in. So it's amazing to me. I've not seen anything like this in a long time. And the other day I thought about the data in Asia where supposedly in Asian patients with IBS, men seek care more than women. And so I always thought that kind of funny. I don't know if it was socially acceptable or what the data is, because being female in GI, all I see men too, but women, it seems like, especially in the constipation area. I wonder if we're going to see a shift and a change that all of a sudden it's okay for everybody to seek care in this country. And since COVID, with telehealth, with stress, we're just going to see this like huge rise. And so the demand is out there. We've expanded our APP program. We already work with a lot of NPs and PAs, which has been great in our group. So we've expanded because of this demand. And so it's really fascinating to watch all of this, particularly in my field in functional GI, but then seeing what we're doing with telehealth, seeing the need, and then we can't keep up with it. So
yeah, it sounds like there's been a lot of flexibility within your practice specifically, but I think at large, and you actually answered one of my follow-up questions, was just the adoption of telehealth or any other methods that you've seen work well or maybe not so much in trying to triage some of this work and get as many patients cared for as possible, knowing that the demand is so high currently.
Yeah, I think I did telehealth. I used to do evening telehealth. We were so backlogged, and now I do it later in the day. Patients absolutely love it. It's a little hard for a new evaluation, I find, but for follow-up patients, it's fantastic. They don't have to worry about Atlanta traffic. They kind of have a plan. They log on. My 85-year-old patients have figured it out, so it's definitely doable. And so I think it's here to stay. And I don't know where I was and not realizing that telehealth was so helpful, like before COVID. but I think it's just the beginning. I think it's going to be, you're going to see a lot more apps and a lot more, sort of integrative apps for all of this stuff, using telehealth, using phones, using, you have experts on the panel that know this more than me, but other areas to integrate these other practitioners. And this goes back to something we talked about earlier in terms of how do you access a psychologist? Like, I can't find really specifically a cognitive behavioral therapist, but we have therapists around. But with telehealth and with having this integrative kind of team approach, I bet that is going to be accessible to our patients, no matter where you live.
Most definitely. And you can bring the diagnosis and the treatment to and from the patient without them having to come to you in this new age, which I think is most important. So thank you to both Dr. Spiegel and Kongara for those answers. That's tremendously helpful.
So, I think that I'd like to just sort of build on that. So we're talking about the increase of patients that we're seeing in clinic, during this time. And, Dr. Brenner, you just gave a great presentation at ACG about some new therapy guidelines from the ACG and new research that is impacting this GI community. Can you expand on that and kind of let us know, those of us who weren't able to attend?
Yeah, sure, Cecile. And thanks for inviting me as well for this panel. So obviously you're referring to the ACG guideline on the management of irritable bowel syndrome that we published in the Red Journal in January of this year. And there are a couple of, I think, important take-home messages. This is the first graded guideline from the ACG in history. And I know Bill was a member of that. And we're really proud to be a part of this. And one of the things that we stressed in the diagnostics section of this was a positive diagnostic strategy, meaning minimizing diagnostic testing. It takes the average person 3 to 4 years to get a diagnosis. They may see 3 to 4 practitioners. And as my colleagues have mentioned to this point, this is something that can pretty easily be done through telehealth and telemedicine. I always say you follow the Rome 4 criteria. If you meet those criteria, there are a few alarm signs or symptoms that you rule out. You need really no diagnostic testing in order to be comfortable with the diagnosis. So this can be a do from home type of process. And I think that's something that we will see more and more with these telehealth types of visits. But importantly, we started to differentiate between treatments and treatment protocols. I think historically, when you look at monographs or guidelines, we say we suggest this, we recommend this. But now, because we have multiple different potential options for treating individuals and good options, we're starting to recommend for or against different therapies. And we really have some robust data on things for irritable bowel syndrome with constipation, irritable bowel syndrome with diarrhea, global symptoms, but still, unfortunately, that mixed or alternating subtype falls at the wayside. Part of the difficulty we have, if you look at the data that's out there and the recommendations for irritable bowel syndrome with constipation, there are the secretagogues like lubiprostone, linaclotide, plecanatide, which all get strong recommendations for use. If you look at some of the IBS-D therapies, rifaximin gets a strong recommendation, oxaliplatin is recommended, elocitron for people that have failed other therapies. And then on the global side, as Bill mentioned, we are recommended a trial of a low FODMAP diet. Behavioral interventions are now recommended. And we have other global therapeutics like fiber and tricyclic neuromodulators. So then the question becomes, well, how do you choose? If everybody's getting a decent recommendation, how do you pick one versus the other? And there have been some recent studies that have come out, specifically systematic reviews, meta-analyses, which overall aren't very helpful. Because when you look at the data for IBS-C or look at the data for IBS-D, really there's not one therapeutic that dominates the others. And on the flip side, none appear inferior to one another. So you get away from these endpoints that are set up by the FDA, the 30% reductions in pain, normalization of stool textures, which really aren't useful for patients. And we don't ask our patients those types of questions when they come into the office and you look at adequate relief. And still, you really can't differentiate. So then we start to drill down to some of the things we think are also important for patients, looking at things like quality of life responses. Because as I just mentioned, I never ask my patients if we had a 30% reduction in pain and a 50% reduction in the number of days where your stools are loose. I say, how are you doing and how is this impacting your quality of life? Because my patients care that they can go out to the movies or to dinner, social engagements, get on planes, travel, etc. And then the other question I think a lot of patients have is, how long is it going to take for these medications to work? So we started to look at some of the data, and like you asked, some of the things we presented, for example, was a study looking at the use of plecanatide. and looking specifically at plecanatide's response on quality of life in patients with chronic constipation and irritable bowel syndrome with constipation. And there are validated studies that can show clinical impact. And what we're able to show is that plecanatide significantly improved quality of life compared to placebo using these validated endpoints. We also looked at one of its competitive therapeutics, linaclotide, and one of our questions was, what's the time to response, not only for abdominal symptoms, but bowel symptoms? And by response, we looked at the median time it took to get a 30% reduction in abdominal pain or discomfort or bloating, and then the amount of time it took to get an improvement of at least one complete spontaneous bowel movement or 3 or more complete spontaneous bowel movements a week. And for 50% of the population, we were able to show that this took somewhere between 2 to 4 weeks, which was significantly less time than placebo. Importantly, however, one of the things we're always concerned about when we hear from practitioners is that we don't have good therapeutics. These medications don't work. And I'd argue that in some circumstances, this is because we do not give these medications enough time to be effective. And Bill can relate to this. Bill published a study years ago looking at the effects of lubiprostone over time and showed improvements from month 1, month 2 to month 3. And in fact, the benefits of lubiprostone were not statistically significant compared to placebo at the end of the first month, but was in the second and third months. And we were able to actually show in these patients with linaclotide that if you stop therapy at the end of the first month, you'd actually miss about 10 to 15% of individuals that would experience significant improvements over a time period beyond that. So again, some other things to look at for our patients, some other things to think about when we are practicing. But the nice take-home message from the guideline is we have good therapeutics. So the last thing I would say is because of that, there are things we're starting to recommend against. And we made a recommendation against using PEG 3350. It's very effective for improving bowel symptoms, but not very effective for abdominal symptoms. We made a recommendation against antispasmodics. The data just isn't that robust, and they don't, again, seem effective for global symptoms. And then there are therapeutics out there that we're recommending against because we just don't know yet. And those would be things like fecal microbial transplants, where there just isn't enough data to suggest. So lots of fertile information, but lots of areas of research forthcoming as well.
Thank you. And our chat is going a little bit crazy and some questions here. So the first question, I think this is gonna be pretty easy for you, Dr. Brenner. Someone's asking about probiotics and what does the guidelines say about probiotics?
Yeah, so there are 2 guidelines that I'll refer to. The first one's the AGA guideline. It looked at probiotics and recommended that these only be used under the auspices of clinical trials. In the ACG, we made a recommendation against using probiotics right now, which was different than the recommendation made by the ACG monograph published in 2018. And that's because there have been, I don't discount the fact that there have been numerous trials looking at probiotics. And a lot of these are positive studies. And when you put the data into systematic reviews or meta-analyses, you'll see overall probiotics as a population appear to be more effective than placebo. My personal bias on this, and I think my colleagues will agree though, is that it is not an all or nothing type of process, i.e. not one probiotic is created equal to the other. So they have to be looked at on their own. And when it comes to the benefits, I think it's strain specific. So you can't look at the genus, you can't look at the species, you have to look at the strain. And when we really drill down on the data, their data is unfortunately pretty poor with respect to its methodology. These are small trials, single center. The definitions for IBS were not using specific criteria, endpoints were not validated, and so we really can't say. So I'm not necessarily a naysayer in using probiotics. I say in 2021, I don't know what to recommend. But I think, we know that the microbiome plays a major role in not only GI disorders, but also other autoimmune rheumatologic disorders. And as we start to understand the microbiome better, these will be more effective. For my patients that want to try them, overall, I can see that they're safe. I do recommend that people take one at a time for a maximum of 4 weeks. And if they see a benefit, it's fine to continue it. Now, my colleagues ask me all the time, do you think it's a placebo effect? And I say, sure, but there's lots of placebo effects in disorders of gut-brain interaction. So if it's a safe placebo effect, I'll throw it back at my colleagues. Does it really matter? So I don't know exactly what to recommend. I don't discount that some patients come in and say that they do better, but I think we need more data, and eventually we'll know the right probiotics to use for specific disorders.
Fantastic. Thank you so much for that. I know that's a question that comes up with patients a lot, so I'm sure that our audience gets that in practice. Really quick before we move on, there has been some questions about CBT and other behavioral therapies as an intervention for IBS. And a specific question that came in on our question and answer box is about anxiety and stress being huge factors with irritable bowel syndrome, and wanting to know what sorts of tools we can give patients as part of the treatment plan, just sort of attacking that anxiety and stress. And the specific is sort of like besides CBT. So cognitive behavioral therapy, I think, is something that's very, very well known and well researched. What other tools do we have in the toolbox for anxiety and stress? And that really can be to anybody that may want to.
Maybe I'll jump in on this real quick. So I'm cognizant of the time as well. There are a number of tools available. First of all, different techniques. So the ACG guidelines refer to this broadly as gut-directed psychotherapies, or GDPs, where CBT is one type of GDP, kind of alphabet soup there. And as we discussed earlier, CBT is a very specific technique. It's there's a very specific framework for CBT, and it really needs to be practice according to the way the book. So, but there's also gut-directed hypnotherapy and mindful meditation, even just breathing exercises. So there are all sorts of apps available for those sorts of generic activities. For example, a lot of my patients use the Calm app or Headspace for general meditation practice, which can be very helpful for all forms of anxiety, gut or otherwise. So I just point out that a lot of people do enjoy that. Maybe later I'll talk more about, I happen to have a VR headset right here because I literally just came across the street, patient was using it. And we do use actual CBT in VR now. We might talk about that more later, but there's a lot of interesting new apps, VR and 2D apps that are being developed for gut-directed CBT and mindful meditation.
And hypnosis. Actually,
and hypnosis, yeah.
Just realize too that there are now there are available apps that are for IBS patients.
Yes.
Like CBT, gut-directed hypnotherapy for IBS patients. And there are even ones that are FDA approved. That's
right.
We could certainly talk about the specific ones if you wish, but realize there are things that are available even as we speak, and they haven't been around very long. Actually, the one that's been around the longest has only been around for like 6 months. So these are all brand new.
Right. Right.
And for people who are interested, and I won't mention names unless people ask, but because these are new types of interventions and people are trying to collect data and see whether or not they're going to be effective, especially as Bill mentioned, the one that's FDA approved. If you have patients who have irritable bowel syndrome, and it is a CBT platform, it's a pre-recorded system. In terms of insurance coverage, I know that's always an issue and question for patients. It's free. It's free for at least through the rest of the year and potentially into next year. So that's a concern, and this is something your patients are interested in. Those platforms are available right now for pretty much anybody who's interested in using them.
The prescription one. The ones that are otherwise available are somewhere in the range of around $40 to $60 a month for a few months. So they're actually not much more expensive, if they're more expensive at all, than medications. It's interesting. You can guess why they're priced the way they are. In fact, obviously people have sat down and figured out exactly what people will pay for these things, and $40, $60 a month seems to be the sweet spot.
I will say, though, I think in addition to all of this, there is a role for traditional seeing a therapist and therapy.
Sure.
And I think that the biggest obstacle for years has been that many of these therapists or many insurance programs, I should say, don't cover therapy per se. So there is a cost attached to this. And for patients, that's often, something that they can't do. But if they can do that or have a plan that covers it in some way or a part of it, I've seen, you can almost tell for the right patient, for the right type of anxiety or depression or both, you see a big difference in their gut symptoms as their, brain symptoms improve. I mean, I think it is still a benefit if that is a form that patients do want to seek out.
Yeah, what's interesting, Kavita, is that if you look at the studies that have compared them directly, face-to-face to digital,
Yeah,
there's no difference in the outcomes.
really.
But to your point, I mean, face-to-face works great, but
Yeah.
digital actually works just as well, which is interesting.
Yeah.
I didn't realize digital has been out that long.
Yeah, so,
That's amazing.
no, I mean, so there are studies like Jeff Lackner's done studies where he's done full service CBT, so 7-10 sessions face-to-face versus minimal contact. In fact, Darren was one of the sites on that study. Minimal contact being one face-to-face session and then all the rest online.
Yeah.
And now there's several studies on minimal contact, and they all show that minimal contact does just as well as face-to-face. And there are also studies with internet-based and book-based, and they all do just as well as face-to-face, which is actually a really fascinating discussion in and of itself. But bottom line is that to your point, whatever you can get, it works. It's just, there's lots of ways to skin this cat.
Yeah, and Kavita, you probably know this as well. One of the questions people have, especially when we finished that minimal contact study, which was less sessions, was, well, this is great, but is this going to last? So I'm done, and what's going to be the overall response? So we've continued to follow these patients, and we published a couple of years ago, at least the 1 year data. We're looking into later time points, but at 1 year, there was absolutely no decay whatsoever. So you do a few 1 hour sessions on your own, like homework, in the comfort of your own home, and it continues to maintain its response over time. And I think we all know that that's a major driver, or at least in the decision analysis of patients sometimes when they choose their medications. They all want something that's more immediate, short term, as opposed to a lifelong type of intervention. So another benefit to that type of treatment.
You know why, Darren? This is my hypothesis, is that it's because during these techniques, what you're teaching two main things. One is you're teaching insight. So you're teaching patients to understand the relationship between something and their symptoms. And then the second thing is you're teaching them strategies to deal with it when it occurs. So you're teaching them to recognize when it's happening, and you teach them what to do when it happens. And it works. And it's a completely virtuous cycle. Once you do that a few times and it works, you're going to keep doing it, so it makes perfect sense that it's durable, and in fact it is.
I've always made the analogy to pelvic floor physical therapy and biofeedback, more importantly, the biofeedback, right? If you learn something works, you'll use the technique over and over again, and it fixes the problem.
Mm-hmm. Yeah.
This is also interesting. So we're talking a lot about what's working now, what's not working now. I think for the last 10 or 11 minutes here, I'd like to talk a little bit about kind of future trends, and I don't think there could be a real discussion around that without talking about some digital therapeutics, new technologies on the horizon. Before we get there, we have one additional question in the comment section that I want to make sure we get to everyone's before we kind of move on to the next topic. And this one is relative to telehealth. So maybe Dr. Kongara, I know you had talked a little bit about telehealth and how it's helping your practice now. Maybe I'll turn this one over to you, but certainly would welcome any insights from any other panelists. But the question is, any liability concerns with telehealth encounters due to the lack of physical examination? I think, the conversation we were just having is actually a good segue into this one, but just generally speaking, if you have any concerns there, and if so, what you might be doing to mitigate them.
I mean, there are, I'm sure with every electronic medical record platform that practices have, there are certain pieces that go into these visits, and there's a self-exam, kind of when you do your physical exam on the telehealth, it'll say self-exam. So if someone's seeing you for belly pain, you've got the video. I make them actually press and see and make sure I'm not missing a gallbladder issue or something really acute, in which case you send them for a CAT scan. But there's a self-exam part. And there is a sort of a statement that says it started off due to the pandemic and the circumstances that we're in, we are using this telehealth platform, and sort of this statement that, we are doing the best we can under these circumstances. So we can't fully substitute for being seen in person and that kind of thing. So there's a statement in all of our telehealth. I'm not a legal person. I kind of wasn't that worried about it. I make sure it's a self-exam and I click the button and it's in there. So we do have that currently. I'm assuming other people who also do telehealth have their own sort of statement, some sort of statement reflecting that. So I assume in terms of liability, I mean, I think you're probably okay given the circumstances that telehealth is in. And I think if it stays, I think people are going to look into that. I have a feeling there's a study on that too. Am I right?
We talked about it. Cecile can weigh in on this one, even as a moderator, because we talked about this with the IFFGD group, and we said, you know, when it comes to telehealth, we're not telling people they can't come to the office and see us. If they're concerned and they want a physical exam, they want to lay eyes, my biggest concern is the non-video visit where I can't see the person, because I think a picture and an image and that type of interaction is worth a million words. Forget 1,000 words, a million words to me. But I think if you sign up for a telehealth visit, and we'll see if this bears out in the legal world, you're assuming some sort of responsibility, right? You as the patient are saying, I don't need this hands-on approach. I am comfortable with this interaction, just discussing this between your space and my space, because the patients have to know. And I think we'd be under more responsibility if we said we are only going to offer you telehealth visits. Then we put the onus on the patient that we're not going to do that exam. But as long as we continue to offer office visits, I think there's some sort of assumption there that we're going to miss a piece of this process. And to what you said earlier, I wholeheartedly agree with you. I think for the first visit, I really want to see those patients in clinic. But if it's something kind of cut and dry, simple, we're modifying medication, how you doing, response to therapies, post-interventional discussions of the results, I think it's very simple to do that in the video health world.
No, that's really helpful. Thank you for those insights. And Dr. Brenner, just to your point, I think there's always a certain level of patient compliance that goes along with wanting to have a successful treatment and have something that works over the long term. You know, if you're not diligent and disciplined, and telehealth, I think is no different. You know, they need to be diligent in monitoring their symptoms and reporting them back to their provider. And obviously, if there's anything of concern or alarming, then, you know, they can make that office visit, as you said. But it's a useful tool, useful supplement, and if used right, can do a lot of good. So we appreciate those answers. So I know we only have 6 or 7 minutes left here. I want to open this last question to you, Dr. Spiegel, given that you just held up a VR headset. So I think you are clearly the one with the most domain expertise here. And this is a big topic. So I apologize proactively for asking you to try to shoehorn this into the last 5 minutes of the call here tonight. But just generally speaking, VR, digital therapeutics, new technology advancements, we talked a lot about this during our mid-year trends webinar, but can you tell us what you've seen, what's within your kind of purview over the last 6 months or so, what you're watching going into the new year, and I guess just what excites you most on the VR side of things and digital therapeutics at large?
Yeah, absolutely. So I'll keep it brief. I think we touched on some of this already. We talked about some CBT apps, and Bill pointed out that there are apps now coming online, coming to market, including with FDA clearance. That's very exciting to see this this sort of evolution of the field of digital health to really applied applications in clinical practice. As for virtual reality, I won't spend too much time on that, other than to say, you know, you've probably all heard that Facebook is now called Meta. Everyone has their own opinion about why that happened, when it happened, and I certainly have no relationship with Facebook, but Meta ultimately stands for the metaverse. And the goal is to build the metaverse. There's 10,000 engineers and programmers in Europe right now creating the metaverse, which is going to be, you know, Internet 3.0. So like it or not, and I don't know if that's a horrifying thing or a fantastical future that we're talking about, this is happening. Like the virtual worlds are happening, and healthcare will be a part of that. So the question becomes, how do we manage that? Obviously, everything from safety and privacy, those are huge issues. If we're talking about Facebook and talking about, you know, HIPAA-related private health information, to just the more enjoyable parts of this, which is how do we leverage these platforms to really make a difference in people's lives? The FDA now has a name for this field. This is not just fringe science anymore. The FDA calls it MXR, which stands for Medical Extended Reality. And there are now a number of startup companies coming through with new, RCT supported digital therapeutics in VR. As I mentioned in the chat, we've been creating our own very comprehensive IBS VR program. In fact, Cecile is one of the very first people to see a very early version of it. You should see what it's like now, Cecile. And we've been really working with patients hand in glove to try and improve it and make it better and better. And our goal there is to actually make that available for free, initially to the research community, and then to beyond that. So our goal is really to methodically, step by step, go through that process before we just release something else. And that's how we approach it here. But it's a big field. It's an interesting time in digital medicine. It's really worth thinking about this. I teach a class called Digital Health Science in our grad school. I think for, docs in the front lines, this may not feel very immediate. How many people are using VR in their clinic? I do. I actually use it every week in my clinic. I use VR, but that doesn't mean most people are. But I think we're going to see a lot more of that over the next 5 years, for sure. Definitely, and certainly over the next 10 years.
No, that's fantastic. And I would ask any of the other panelists who might have some thoughts or inputs here, if you see any of the kind of new advancements in technology, VR, digital therapeutics, having a kind of a practical implication and how you're going to treat, diagnose patients moving forward, if you're kind of taking a wait and see approach, if you've already integrated anything into practice that you're seeing help optimize the process of treating some of these chronic disease conditions, IBS and the like. Maybe Dr. Kongara can start with you, and then Dr. Chey and Dr. Brenner.
I think, just in terms of, we've used breath testing for a long, long time. So that's something that's great, because it used to be done in a lab. It would take several hours. And there are labs, academic centers, that still do probably a larger variety of the different substrates to look for different things, and patients seek care to be in one place and get everything done. But it's been so nice to have that as a take-home easy test, so patients can, if we're looking for SIBO, or if we think they have lactose intolerance, I tell them you can avoid milk products for 2 weeks, or there is a test, there's a test for something. And the fact that it's something they can take home and do on their own, that's been great. Patients are really seeking that out. And in terms of integrated, I agree with Bill. I'm not an integrative practitioner. I'm traditionally trained from the start, open-minded. We bring in these pieces and learn from other areas to find a commonality. So whether you call it leaky gut and we call it SIBO, these things, we've got to sort of allow patients to do these things and make it easier. Pelvic floor therapy, we've offered this, that's currently done in a hospital setting at most places, but we've hired pelvic floor therapists. They come to the office. I don't know how that could be. I have a feeling that could be done virtually at some point. You can be in a room and wear the headset and you can watch the diagrams and have a sensor. I can see that happening, chronic pain, I could see sensors in the belly and mind body, and just like with biofeedback helping that. So I think the apps for, as far as dietitian and nutritions, we talked about the apps in terms of, there are FODMAP apps out there. I think it's a little cumbersome for a patient to do that on their own. It could be very, very restrictive, but to use it as a starting point is great. And then we already talked about, we hit the cognitive and the meditation and all of those apps out there. So each of these pieces we've sort of slowly been incorporating, but I see that at one point you're going to have an integrative approach in the way that we define it, and bringing these pieces so a patient can be introduced and it can be done on their own with our guidance.
That's great. We appreciate that. I know we're running up against time here. I will turn it back over to Jason and our team in a minute, but Dr. Chey, Dr. Brenner, if there's any kind of closing remarks that either of you may have on this area, or just integrated digital therapeutics, advancements, technologies, just anything you're excited about, please.
A quick comment, Craig, and that is that so by way of disclosure, I have a leadership role in an organization called GI On Demand, which is a joint partnership between GastroGirl and the American College of Gastroenterology, and they're developing one of these full stack integrated care platforms. And the idea is to offer face-to-face dietitian services, eventually behavioral health services, but more importantly, to do what probably people are wondering about right now, which is how do you sort through, by the way, this is my puppy that's jumping up on
Mhm.
the top of her head. But how do clinicians sort through like all the different options? Well, GI On Demand hopes to be a place that curates those different options and makes those available on, with a one-stop shop, including at-home testing, like Kavita was talking about, breath testing, et cetera. So, and I think, GI On Demand will just be one of several different, there are several companies going down the same path, slightly different approaches, but there are going to be ways by which, for example, a small community gastroenterologist will be able to access all of these different things we're talking about. Right now, I know it seems like it's out of reach, but it won't be very much longer before it's not out of reach anymore.
I hope we're close, for
Yeah.
sure. That's the ideal world. Dr. Brenner, I'd leave it to you to close things out. If you have any final remarks or inputs here, by all means, please.
I think everything's been said. And I hope that the panel and the audience listening tonight isn't freaking out that we're all going to be eliminated by virtual reality and automated devices and computers, kind of the way the checkout counters are at your grocery store lately. You don't have to see a person anymore. You just go bleep on your own, put your credit card against the little machine, don't swipe, and you walk out the door. At the end of the day, realize that, it still takes the clinical acumen. You can't get to these modalities and technologies without making the right diagnoses. And I still think that you need, a good practitioner and a sound base to be able to get there. But these are going to certainly open up this idea of, I guess I don't necessarily use the term integrated, interdisciplinary medicine. To Bill's point in the semantics, I think it is a little bit important because I've seen people come to my pelvic floor program because it was called the integrated program, thinking it was going to be more of a natural type of thing.